Ready.
Okay. Okay, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good evening, ladies and gentlemen, fellow colleagues, respected professors, doctors from Indonesian Radiation Oncology Society or IROS, and fellow radiation oncologists from other countries, and even from other disciplines tonight. Some respected cardiologists I see is here, and hoping some more will join us later on with us. Very happy to welcome everyone here tonight and looking forward for many good collaborations in the near future. And of course, we from IROS hope that you are all in good health and good spirit always. So this is our second webinar from our education series in collaboration with Cipto Mangunkusumo Hospital, Faculty of Medicine Universitas Indonesia, and the Ohio State University, the James Comprehensive Cancer Center. The first webinar last month was a great success with the topic of single isocenter multi-target stereotactic radiosurgery, a very advanced topic too. And tonight we will talk about another advanced innovation, which is about cardiac radioablation. I believe is currently a trending breakthrough in the field of radiotherapy. Very exciting, very challenging, and I'm sure we are all keen on learning more on this. And as planned in this series, the residents from both our center will play a bigger role in the educational webinar series. So I'm proud of the co-moderators for today, Dr. Vito and Dr. Nicole, representing both sides of our centers. And we will also have our residents today in the panel, Dr. Gea and Dr. Alex, and of course, along with other experts in the panelists. So without further ado, I will hand over now to the moderators to later on they will introduce our president, speaker, and lead the session. So please, Dr. Vito, Dr. Nicole, the floor is yours now.
Yeah. Thank you, Dr. Mayang. Am I clear?
Yes.
Yeah. Okay. Thank you for a nice introduction, Dr. Mayang. So let us introduce ourselves first. I'm Vito, radiation oncology resident from Indonesia, and I'm here as a moderator in this session, together with my far away colleague, fellow radiation oncology residents from the USA, Nicole. We are here today because of the collaboration between the Faculty of Medicine, Universitas Indonesia, Dr. Cipto Mangunkusumo Hospital, and the Ohio State University, the James Comprehensive Cancer Center under the initiative of Prof. Suhartati and Dr. Andrea Arnett.
Yes, thank you so much for the kind introduction, Dr. Mayang. Today's session, as you all know, is going to focus on radiation oncology meeting cardiology. So we will talk about cardiac radioablation, one of the most exciting topics in radiation oncology, because it makes two seemingly unrelated fields and two seemingly unrelated professionals come together as a team.
Yeah, indeed. I remember that once my supervisor during my training to be a medical doctor, he always reminds us that treating cardiac arrhythmia encompasses rate and rhythm control. But most of the time, it is hard to achieve the goal. So that's the aim of these sessions, is to give the solutions of that problem.
But before we start the session, I would like to remind kindly all the participants that you are more than welcome to ask questions, either the speakers or the panelists through the Q&A box that you can see in the Zoom, or raise your hand at the end of the session. We will have a discussion dedicated to your question. And now we would like to have a welcome greeting from the president of IROS, Professor Suhartati.
Yeah, thank you very much thank you very much. So, Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. Good morning, ladies and gentlemen, my fellow colleagues in Indonesia and neighboring countries. And good evening to our collaborators from Ohio State University, the James Comprehensive Cancer Center. Dr. Andrea, how are you? All the best always for you. And our speaker today is Dr. Jeremy Brownstein and fellow colleagues. I'm grateful that we gathered here today to continue our collaborative project between IRS and OSU, Ohio State University. This is the second webinar in the series after the first webinar last month. It's mentioned by Dr. Mayang about the single isocenter multi-target SRS for multiple brain metastasis. Today, this webinar will explain the new breakthrough in the utilization of radiotherapy, not on cancer. So this is a very interesting for us, for all of us. We will talk about arrhythmia. That's why we have right now a participation from 343 participants. And also we have from international 88 participants from international. We have from China, India, Korea, Myanmar, Malaysia, Thailand, Bangladesh, Germany, even from Germany, Philippines, Japan, Saudi Arabia, New Zealand, and the United States. So now as we know along with the development of the technology in radiation oncology, more advanced techniques are available to deliver higher dose to a specific tissue or organ with low side effects, and also importantly, we can deliver radiation precisely, adaptively, following the movement of any organ, such as lung. Usually we do it in lung cancer or lung metastasis with the technique, the stereotactic body radiotherapy. Now, because of this more and more advanced technique, it is also possible for us to target the heart, in beating heart. For colleagues from not radiation oncology, some cardiologists, I'm sure that they are here right now, probably here. Yes, we can do it. We can give radiation to the beating heart precisely and with a very minimum harm to surrounding tissue. Now, this is a very good match actually with cases of arrhythmia. The history of research of arrhythmia using radiation is actually not new. I'm sure we will hear more about it on the talk and discussion today. I myself very excited to hear about this. And when our modality of radiotherapy can be well applied to help more people, more patients, then it will be a great benefit for anyone. And of course, we will go forward in strong collaboration with our fellow colleagues in other disciplines. This lecture can be the benchmark for further collaboration between radiation oncology and cardiology, particularly in our country, who have never had direct collaboration in the past. It will be a step to the first future for us to set up the first stereotactic cardiac radioablation in the country. We will see. And we should follow closely the advancement of this topic in the world, and also follow every possibility here and in our center. In the panelist room, we have Dr. Handoko, our radiation oncologist. Hi, Dr. Handoko, and also Dr. Andrea from Ohio State University. And also the residents from both sides. We have Dr. Alex Ritter, hi, and my residents, Dr. Gea. I thank the IRORA. IRORA is the society from our residents and also residents for participating more actively here and in the next webinar too. This time is Dr. Vito and Dr. Nicole as a moderator of the session. And also I would like to greet our guest panelists from the Korean Society for Radiation Oncology, KOSTRO, Professor Ji Yoon Chang. She is the principal investigator of the cardiac radioablation project in Korea. I'm sure she will bring her expertise and experience to the discussion today. Thank you everyone for coming. And I see many colleagues from Indonesia as well as other countries, as I mentioned already before. Please enjoy the session. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you so much for these kind words and for your very warm welcome, Professor Suhartati. Vito shared with me before that you are one of his favorite teachers, in fact, probably one of the best ones he's ever worked with, because you inspire students to strive for the best and be dedicated to their patients and look for new avenues and extend their horizons, including even expanding into the horizon of radiation therapy into fields such as cardiology. And for those of you who may not know Professor Suhartati, Sati. She is extremely experienced in the field of radiation oncology. She became a radiologist in 1987 and studied radiation oncology at Universität Münster in Germany in 1988. Currently, she's the president of the Indonesian Radiation Oncology Society, and recently she received honorary member award for her contribution to the entire field of radiation oncology at the 37th European Society for Therapeutic Radiology and Oncology meeting in Barcelona in Spain. She has co-authored numerous publications in a range of topics, including radiation oncology physics and molecular oncology, and her current areas of interest also include head and neck tumors, breast cancer, stereotactic radiation, and CNS tumors, for which she has been actively sharing her expertise on numerous international forums and platforms. She actively participates in several professional oncology organizations. She served as a past president of the Federation of Asian Organizations for Radiation Oncology, Southeast Asian Radiation Oncology Group, and the chairperson for National Cancer Control Committee of Indonesia. She is also the national project coordinator for several projects with International Atomic Energy Agency.
Thank you.
Right. So now we proceed to the next sessions we are all waiting for, the cardiac radioablation, radiation oncology perspective by Dr. Jeremy Brownstein. Please, Dr. Jeremy Brownstein is radiation oncology on the faculty at the James Cancer Hospital Sloan Research Institute at Ohio State University. He earned his MD from Stony Brook University, completed his residency at Duke University, and completed a clinical fellowship in proton radiotherapy at Massachusetts General Hospital. His primary focus is on thoracic radiotherapy and is currently leading several investigator-initiated trials exploring the use of novel radiosensitizing therapeutics to improve treatment outcomes in lung cancer. He's working with a team of cardiologists and electrophysiologists. He has helped develop and grow a robust clinical radiation program at OSU. His team partnered with Washington University and University of Alabama to publish a guide contouring atlas to help introduce radiation oncology to the nascent field cardiac radioablation. So Dr. Jeremy Brownstein, time is yours.
Thank you, everyone, for this wonderful opportunity to speak with you today. So I'm gonna be chatting about cardiac radioablation, and I'm gonna be doing so from the perspective of the radiation oncologist. So I'm gonna be mentioning some of the relevant electrophysiology as well, but keep in mind, this is from my uninitiated perspective. So cardiologists in the audience, feel free to disagree with my interpretations, but a lot of the talk will focus on what I think is useful for us to know to foster a good communication with our cardiology colleagues. So a brief outline of the conversation, we're going to just have a brief introduction to ventricular tachycardia. We'll talk a little bit about the relevant pathophysiology and the relevant anatomy as well. And then we'll talk a little bit about how we start to localize the target for cardiac radioablation and what different diagnostic modalities we have available to us. We'll speak a bit about the treatment planning and delivery and some relevant considerations in that. And then I'll briefly wrap up with a short case report of one of the several patients we treated recently at OSU. So just as a brief introduction, ventricular tachycardia is an abnormal rhythm that is defined by the fact that it is a true tachycardia, heart rate over 100 beats per minute, but it's also a wide complex tachycardia. And ventricular arrhythmias, talking about both VTach and VFib, account for most cases of sudden cardiac death, and they kill, in the United States at least, approximately 300,000 people a year, and account for 5.6% of all of our mortality. So it's a pretty substantial contributor to mortality. So there are several different types of ventricular tachycardia. There's a monomorphic VT, and this is most commonly caused by congestive heart disease or some more rare diseases like hypertrophic cardiomyopathy or sarcoid. And this is the relevant type of VT we're going to be discussing today. But there's also some other types of ventricular tachycardia, like polymorphic VT, which most commonly happens from prolonged QTC intervals, and we won't really be speaking about that. So to start things off, I wanted to quickly talk about this seminal paper that was published in from Washington University in Circulation in 2019. And they are addressing a very important patient population with refractory ventricular tachycardia. So these are people where they've been on antiarrhythmics at baseline and were still having episodes of VTAC, and many of them had undergone catheter-based ablations. And despite that, they were still having these episodes of ventricular tachycardia. Now, in this case, there's not many treatment options available. Sometimes patients can have something called a sympathectomy, which kind of removes sympathetic input into the heart. And that can be a little bit of a temporizing measure, but it's not curative. And then the only real curative approach would be a heart transplant. And that's not always available, obviously. So this patient population that they were looking at is a patient population that previously had a very poor prognosis. So they treated 18 patients with this refractory ventricular tachycardia, and they prescribed 25 Gray ×1 to a very carefully designed field that was focused right on the area of concern. And they had a dramatically positive response. So in essentially 18 out of 19 of their patients, they had a reduction in the episodes of VTAC. And I think majority of the patients had a greater than 75% reduction. So this really showed that we can really move the needle with using radiation to help this previously this previously poor prognosis population. So the pathophysiology of the type of ventricular tachycardia we most often encounter is important to consider. So we're most frequently, when we're doing these procedures, dealing with a reentrant tachycardia. And this is kind of born of this idea that you don't quite have, you have cardiac tissue that's not quite living and not quite dead, but it's somewhere in between. And that ends up causing a lot of the trouble. So normal myocardium conducts the impulse of electricity throughout the heart rapidly at about 80 to 90 centimeters per second. And that's as the heart beats, that impulse travels throughout the heart. And normal myocytes, once they have an impulse that travels through them and they contract, they have this refractory period where they cannot be re-excited. And this helps to prevent myocytes from starting arrhythmias and helps to keep the action potentials going in the right direction. Now, if you have an area of complete or dense scar, this actually doesn't really harm things much because the electricity just doesn't go through it, and it really doesn't contribute to the depolarization of the heart. So it's really kind of not seen from the electrical perspective. Where the problem arises is if you have partial scar, and through partial scar, you can have slowed conduction, which has these impulses traveling less than 10 centimeters per second. And this is where the problem can happen with reentrant tachycardias. So the way that this can play out is in certain situations, you can get the formation of what's called an isthmus. And that's essentially an area where you have dense scar that has a narrow pathway of partial scar that goes through it. And this allows for a bottlenecking of the electrical signals. So at the entrance of this isthmus is what they call the critical zone, where the action potential is actually slowed the most. And then it travels through this isthmus, and then it reaches the exit site. And this is where the action potential, the abnormal action potential, first encounters a healthy myocardium. And then this abnormal wave spreads through the healthy myocardium quickly in what we call the outer loop, and it can then re-enter the critical zone. And that loop is what can create these reentrant tachycardias. So the goal of ablation of any kind, including the catheter ablations, is to turn this partially dead myocardium that happens at the critical zone in the isthmus to a completely dead myocardium, just so that the electrical impulses will not travel down this dangerous road anymore. So to start to think about how we approach this, the most important initial consideration is left ventricular anatomy. And this is a somewhat alien topic for radiation oncologists because we're usually trying to avoid the heart, not consider its microstructure. But in this case, it's very important. So the left ventricle approximates a cone, but the cone is not just straight up and down. It's pointed obliquely. So the tip of the cone is actually pointed anteriorly, laterally, and inferiorly. And that tip we call the apex. So when cardiologists think about the heart, they're not thinking about it from this oblique point of view. They think about it from the perspective of the left ventricle. So when they do that, there's a couple of different ways they can think about it. Well, if you take that cone and you slice it completely axially, what you're going to see is you're going to see a circle. So that's the most common, or one of the more common ways to look at the heart, is what we call the short axial view. And this is kind of looking down the barrel of the left ventricle down towards where you have a perfect circle. And what we see here is that the right ventricle is over here, and this is the septal wall. Now, the nomenclature that's frequently used by cardiologists is not entirely intuitive, so it's worth discussing. The side of this circle that is closest to the right ventricle, that is the septal direction. And then opposing that is the lateral direction. The side of this circle that is pointed up in this orientation is anterior. And all of that seems to make sense, but the part that I think is a little non-intuitive is opposing the anterior direction is inferior. We're used to posterior being the term, but in this case, this is called the inferior wall. So that's an important consideration. So this is one perspective. This is just if we were to slice the cone so that we can see the short way so that we can see the circle. But there's two ways we can slice it the long way so that we see more chambers of the heart. So there is the 4-chamber view where we're slicing that cone, and you can see that we can see all 4 chambers of the heart. And I will go into this in a little more detail, but the left ventricle is divided into some regions and segments that we will discuss a little bit further, and you can see them outlined here. And then there's another way you can slice it. You can slice it the kind of the sagittal way so that we're only seeing 2 chambers of the heart, where you have the left atrium and the left ventricle. So these are the cardiac specific views that cardiologists are more accustomed to viewing the heart from. But our problem is that's not the way that the heart appears on our planning scans. So our first case at OSU, one of the more challenging parts was we were sitting next to our cardiologist colleagues, and they were trying to describe the location that we were targeting, but they just couldn't visualize it on our axial scans. And I started to rotate the heart into the orientation they were describing. And that's how we were able to contour. And it occurred to me that doing that rotation was very difficult. So I thought it'd be helpful to create an atlas and a guide to explain how to do that. So I ended up collaborating with some amazing people at OSU and the team at Washington University, Cliff Robinson and Phil Kukulich. And we kind of went through a methodical way that you can reorient the heart. And we'll talk a little bit more later about how you can divide the left ventricle into the segments. So when we first get our cardiac scan, we first get our planning scan, what you're going to see is the heart kind of oriented obliquely like this on our axial view. So the first thing I like to do in terms of getting this rotation correct is to find the apex. The apex is a little tricky to find, and it may take some adjustment. But the point that you're trying to find to define the apex is the leftmost, inferiormost, and anteriormost part of the heart. So you're going to try to localize this on your orthogonal views. And once you have a pretty good approximation, then you can really start to do your rotations. So here it's located on the axial view. But if we look at the coronal view, and this is actually from the atlas, you can see that this apex sits over here. And our first rotation is going to be to try to make this apex at the bottom of the screen. That's always going to be our goal in terms of the coronal and sagittal views, is to try to get the apex at the bottom. So we make this rotation and see the apex down here. And then when we look at the sagittal view, it's not quite at the bottom. So we're going to make another rotation so that it is at the bottom of the sagittal view. And we're going to tweak our rotations, because you might find after you start doing this that the point you thought was the apex is not really the tip of the triangle. So you're going to need to readjust what you think is the apex. But the goal is to make it so that when you're looking at these coronal and sagittal views, you see this triangular structure with the point pointed inferiorly. So that's almost there, but not 100% to the appropriate views. Once you've gotten to the point where you're oriented along the long axis of the ventricle, which is what you're doing here, the long axis being the line that connects the apex to the base, then what you have to do is make sure that your axial view, which is now showing that short axial view, is rotated appropriately so that the right ventricle is on this side. And what you're going to try to do is make sure that this coronal axis is more or less bisecting the septum. So there may be portions, say, near the apex where the septum kind of is a little bit more eccentric and is up here. And then there may be portions where it's a little bit more closer to the base, but on a whole, I mean, more eccentric down here. But on a whole, you want this coronal axis to be more or less going down the middle of the septum. So once you've done all of that, you are in the appropriate view. So once you're in the appropriate view, you then need to be able to figure out where the target is. And this was a challenge in cardiology about 15 years ago, was different imaging modalities would refer to the heart using different anatomical terms. So cardiologists may refer to certain anatomical terms, whereas they would use different terms when looking at a cardiac CT. And this didn't really foster a healthy communication. So the American Heart Association came out with this 17 segment model to methodically divide the left ventricle into 17 segments that everyone can agree where these segments are. This is really important because this is a conical structure and it has radial symmetry. So there's not a lot of boundaries that are obvious when you look at a scan. And doing this allows everyone to kind of agree which region of the left ventricle we're talking about. So the left ventricle, when you're looking at the long axis, is divided more or less into the true apex, which is just the very tip of the heart. And then the remainder of the long axis is broken up into thirds, where you have the apical segments and the middle segments and the basal segments. And that really starts to help us start to at least know which part of the ventricle we're talking about. But then we also need to divide up the ventricle when we're looking at the short axial view, so we can figure out how to distinguish the top of the circle from the right part of the circle. So each of these regions of the heart, the apical, mid, and basal regions, are further divided into segments. So the basal and mid segments are, because those areas are a little bit thicker on the cone, are broken up into 6 subdivisions, 6 segments. And then the apical segments, because we start to get a little bit narrower, are only broken up into 4. And then the true apex is then segment 17, which is probably the smallest segment. So when we are looking at our short axial view, these segments can be defined by essentially going through and figuring out where the septum is. That's the most helpful thing in terms of defining a lot of these segments. So the true apex, in speaking with Bill Kukulich, we were trying to figure out a way to define the true apex. And we said the true apex ends at the first slice when you're scrolling basally from the apex that you can see the lumen. So that's the end of the true apex. And then everything above that is going to be an apical segment. So within the apical segments, the 4 apical segments, since there are 4 of them and we have a circle, they're going to be separated by 90 degrees. So each of these are going to comprise an arc of 90 degrees. Now, the septum itself is the only real part that we can readily distinguish as having a boundary. So the septal segment is defined first, and that's going to be, in this case, segment 14. And then we're going to define the remainder of the circle, the remainder of the 270 degrees as anterior, lateral, and inferior, and those are equally divided among that. And what I like to do is try to have the, try to make it so that the location of these boundaries is 30 or 60 degree increments around the circle, so that you can talk about these areas as like o'clock position. So this would be like the 10 o'clock position. Now, you can see this is a little bit eccentric, where there's more of the septal segment on the inferior portion than on the anterior portion. But that's because when we go further up the heart, you can see it becomes a little bit more eccentric the other way, where we have more anterior. So it's not going to be a perfect bisection in every slice. So when we go up to the mid and basal portions, because there are 6 segments in each of these, there's going to be, each one of them is going to comprise a 60-degree arc. And in this case, there are 2 septal segments. We're talking about the anteroseptal segment and the inferoseptal segment. So those will comprise 120 degrees, and then the remainder of the circle will be divided evenly among these 4 other segments. And the same thing holds true in the base. And you can see this is kind of the coronal view that gives us a sense of where these slices are taken from in terms of the, this is the 4-chamber view, and we can see the levels that these slices are taken from. So now that we have an idea of a language we can use to describe where a target may be, let's talk about how the how electrophysiology may be considering a target. And I'm not trying to discuss this as a way that we should be deciding the targets. We shouldn't be. It's the job of the cardiologists. But it's helpful, I think, if we know what sort of considerations they're having, so that we can have a meaningful conversation with them. So the key to in a lot of these cases, my understanding from my colleagues, is that we're trying to find the isthmus, and that's going to really be our target, is the isthmus. But the problem is that the isthmus is difficult to observe directly. In our world of treating cancer, a lot of times we can identify the tumor or the lymph node basin that we're targeting based upon the anatomy. But the isthmus is not an anatomical feature, it's a pathophysiological feature, and you can't always see that directly. So we need to look for indirect signs of where the isthmus is. So clues to finding the isthmus are that the isthmus will generally be in or around a scar. And that's helpful, but unfortunately, a lot of these patients will have very large areas of scars. So that may not narrow it down too much. What is helpful in a lot of patients is that the isthmus will be attached to the exit site. Now, remember, that is where the action potential, the slow action potential, leaves the is leaving the narrow isthmus and is first encountering healthy myocardium. And this is actually something that we can localize a little bit easier using our clinical EKG from the ventricular tachycardia. So a general strategy, and each case is different, but a very broad brush general strategy is to try to locate the exit site and then find that and an adjacent segment, maybe with an adjacent segment of scar that looks concerning, and that exit site plus that adjacent area of scar could potentially be our target. So how do we find the exit site? Well, one of the most helpful initial tools is actually looking at the EKG. And just to remind everyone, I needed reminding too, because we haven't done this since medical school. The EKG consists of usually 12 leads. 6 of them are placed in what we call the precordial leads. Those are the V1 through 6. And then there are also chest leads, as you can see as well, that go the right arm, the left arm, and then the foot. So there's these numerous different leads, and what we're going to be doing is using these leads to help us figure out the vector of the ventricular tachycardia, and that'll help us figure out where it's coming from. So there's this really helpful paper by Andrew et al, and I use this very frequently to have an initial sense of where we're going to be targeting before I go over the target with our electrophysiologists. And this paper goes through a methodical way based upon the clinical VT of where you can find the exit site. And you know, it's not foolproof, but it gives a good sense. So one of the first clues we can get is from the fact that leads V3 and V4 sit directly over the apex, that point of the heart. So when V3 and when we're looking at the EKG of the ventricular tachycardia, if V3 and V4 are net positive, meaning that the spike, the top part of the spike is bigger than the bottom part, we can be confident, or we can consider that the exit site may be in the base. And that's because if it's net positive and the leads are down here, that means that the wave of depolarization, that profound contraction is going to be moving from the base towards the apex, resulting in that positive deflection. And remember, we're not seeing the isthmus, we're seeing the contraction of the heart after the electrical impulse leaves the isthmus. So this is showing us from the exit site contracting the rest of the heart. So if V3 and V4 are positive, then we can consider that the origin may be in the base and spreading this way through the heart. Conversely, if V3 and V4 are net negative, we can consider that the exit site may be starting here and spreading this way through the heart. And then if V3 is positive and V3 is negative, or vice versa, or they're both kind of isoelectric, then we're maybe looking at an exit site in the middle portion of the heart. So already we're getting some important information about where the exit site is. And here's an example from this paper where we're looking at this EKG and we localize the V3 and V4 and we realize that they're both positive. So in this example, we can consider that the exit site is probably in the basal portion of the heart. So now it's important to consider, now that we know where it is on the long axis, now we got to consider where it is on that short axial view on the circle, which is it at 1 o'clock or 6 o'clock? So we can, to do this, what we're going to do is we're going to look at the EKG chest leads and see which area is which lead has the tallest from top to bottom QRS complex. And this will tell us primarily where, generally speaking, where it is on the chest. And if for instance, 3 is very positive, we're going to be looking that it's coming from this area over here. Now, and that's because the exit site would be here and traveling this way. Now, a lot of times these leads will correspond to boundaries between segments, and to break those ties, we'll frequently use the second tallest magnitude to help us figure out which whether or not it's on this side or on this side. So in this case, in the paper, they show an example where the tallest QRS complex is in lead 3 and it's primarily negative. So we're looking here and lead 3 is primarily negative. And so that means that it's probably coming from over here. And then when we look at the second tallest, we figure out that it's AVF. So that means that if we're deciding between 3 and 4, because we already figured out it was in the base, we're going to lean more towards 4. And indeed, that is where, according to this method, you can kind of deduce the exit site is. So that's helpful in terms of finding the exit site, but that's certainly not enough to make sure we're targeting the isthmus, because the exit site is actually not the problem spot, it's attached to the problem spot. So to find the isthmus, we're going to be frequently looking at other modalities that are looking for scars. So one of the, and I'm not going to go through all these in detail, I'll have the slides for everyone's reference. The electrophysiologist can use electroanatomical mapping to localize scar. And in this case, in this system, they're going to be measuring the endocardial surface with probes, and they can look where electricity has trouble traveling. And in this slide, the scar is in red and the healthy myocardium is purple. And they can also use techniques where they stimulate the heart at various points and try to either induce the VT or replicate it. And they are going to be comparing the clinical VT to the one that they're producing by stimulating different points. And they can use this to try to help figure out if they find one that matches perfectly. That could be very helpful information. So there's other modalities like a cardiac gated CT. So we use 4D gating to look for respiratory motion in treating lung cancer. Cardiologists use a 4D CT as well, but it's not looking for respiratory motion. It's going to be gated to their cardiac cycle. So with this, they can look for things like hypo or akinesis in some of the walls. And they can also see thinning in the walls, which can both be indicative of scar. MRI can be very helpful. Not all patients can get this because a lot of these patients have pacemakers and AICDs, and only some of them are compatible and only with certain MRIs. But when it's available, late gadolinium enhancement is a very good surrogate for scar. And one of the things that we use very frequently at OSU is nuclear medicine to help localize scar with SPECT, or what we use a lot is PET, where we're doing a FDG scan like we would for cancer, except in this case, the scar, the target, is going to be the area without uptake, because normal healthy myocardium should have uptake and because it's metabolically active. So all of these different modalities are phenomenal, but none of them kind of accomplish the three goals simultaneously by themselves. So we want a modality that can give us where the exit site and isthmus is located, so the physiology. We want a modality that can tell us the anatomy of the scar location. And we also want a modality that's easy to fuse with our treatment planning systems. And as you can see, there's not one that covers all three of these. So in a lot of our patients, in all of our patients, we're wanting to get multiple different modalities simultaneously so that we can use the overlapping strengths and how one offsets the weaknesses of the other. We can use those to try to make sure we're targeting the best area. So at our site, we want to make sure that we have a modality that is telling us the exit site, and then usually at least two modalities that are helping with the scar. And hopefully one of these can be fused with our treatment planning system. So I will frequently try to get a PET on our patients. Another helpful thing is to have this anatomical mapping, which can provide information on both the scar and the exit site. But unfortunately, as of now, we don't easily fuse. So our targets are frequently, and I will say frequently, but each patient is different, but we're frequently including the exit site and the isthmus, or ideally the isthmus, and then up to one additional segment of adjacent scar. So the way that we've been employing this at OSU is that we are only doing this in very select patients. So these are patients for whom there are very few treatments available at this point, people who have recurrent ventricular tachycardia and are failing multiple antiarrhythmics, are getting frequent AICD shocks, and have undergone catheter ablation that was unsuccessful, or if they have like mechanical valves, can't get a catheter ablation, and who may not be a candidate for transplant. So these are people where there's not really a lot of options. And I think patient selection, given that this is a novel field, is very important. So we will go through in painstaking detail with our electrophysiologists, and we'll have a big meeting together and define on the short axial view exactly where our target is, as we call that the CTV in this case. And then we will do an expansion to create our ITV. And there's a couple of ways to do this. The way that Cliff and Phil have discussed, and I think is the most safe and inclusive, is to consider the motion of the heart. And the reason we can't just do a normal ITV a lot of the time is because the boundaries of the segments are not intuitive on our planning scans unless you're very careful about defining them. So it's not so easy to look through the phases a lot of times and see where the segment moves between different phases. And we'll be doing a respiratory gated scan for our 4D scan. But looking through those phases, you can see how the heart moves in general. And if you compare that to the scan that you're contouring on, we usually do that on the average, you can see that the heart may, at its most, move 3 millimeters superior and maybe 4 millimeters inferior, and a certain direction left and right. And if you do an expansion based upon those cardinal directions, that's going to likely be sufficient to cover your area. Sometimes I will personally go through and try to make sure that it's including the segments as those segments move, as I became more comfortable with localizing the segments. And but that's probably not something to do right away. And then we will, at our institution, we will be using a 5 millimeter expansion on our ITB to get our PTV. Now, one thing that's very important to consider is what dose constraints to use. And this is in flux, and I think different people may have different opinions about this, but I can say what we do at our institution, and we're, as you may know, the prescription's typically 25 gray times 1. Now, we'd like to make sure our target isn't too big. 150 cc's kind of is where most of the targets in the Washington University series were below this size. And I get a little concerned when we get them too big that we could start to cause heart failure or worsen heart failure. So I like to keep our PTV size below 150 cc's. And then our constraints, spinal cord is of course always important, but you're not very close to it, so it's not likely to be a dose limiting factor. The bronchus is usually not too close as well, but where we can really start to have difficulties, and Dr. Cheng has written very eloquently on this, is with our GI organs. So if you're dealing with inferior wall targets, the inferior wall of the heart's going to sit right on top of the diaphragm, and frequently right on the other side of it is the stomach. And as we all know, the stomach is very radiosensitive. So I try to be as conservative as possible with the stomach, and I'll contour the stomach and the esophagus and put a 5 millimeter margin on them and have a max point dose to that PRV of 22 gray. And then we'll have a volumetric constraint on the stomach of 17.4 gray. Sometimes, just to be extra conservative, I'll make sure this is the max dose of the stomach and the esophagus as well, and also the large bowel, the splenic flexure of the large bowel can be nearby as well. So that's an important consideration. Great vessels are sometimes nearby, and then we try to keep our chest wall and ribs reasonable. I don't think I would limit a treatment because of those, but that's an important quality of life consideration. So I just wanted to briefly discuss a case and show how this kind of worked out in our clinic. So we had a 58-year-old woman who had an ICD with heart failure with an EF of 30%, and she was on amio with ongoing episodes of VT. Unfortunately, she developed an infection in the pocket where her ICD was sitting, needed to get it removed. So she kind of lost her parachute, so to speak, in terms of saving her from these episodes of VT. And she was not a candidate for transplant because of many medical comorbidities. So she was really kind of in dire straits. So we wanted to offer this to her. So our electrophysiologist did a mapping study, and off the bat, we can see when they induced the clinical VT, we can see that leads V3 and V4 were primarily negative. So this let us know that we were probably dealing with an apical target. And then looking at our chest leads, we noticed that the tallest one was lead 3, and it was primarily negative. So that means the VT is spreading this way from the exit site, which, considering that it's in the apex, is more or less implicating this 14 and 15 area. So this is our initial thoughts of the exit site. But then we gathered some additional information. So we looked at our substrate mapping, And we see there's this large amount of scar on our substrate mapping, this red area that's involving a lot of the segments, 3, 4, 9, and 10. But we can maybe make out what looks like an isthmus in this location here. And we also looking at other imaging modalities, the EKG gated CT, we see that we did include these segments as well, but this one also identified 5 as an area with scar. So we have a large scar and we have an exit site. So we incorporated our segments 9 and 10 from knowing that there was scar there. And this ended up being our target, where we're getting the basal portion of 14 and 15 and the apical portion of 9 and 10. And the way that this looked on our contouring is this blue, this is showing a short axial view, and this blue is kind of our target outlined here, our CTV, and then the orange is our ITV, and you can see that outlined here as well. And then the PTV is a 5mm expansion. Now, I know I had told you guys inferior walls can be problematic, and sure enough, the large valve in the stomach were right beneath our target. So I used a dose painting technique to get in as much dose as was safe to the PTV that was overlapping or near these GI organs. And as we got further away, I put in as much, I went up to full prescription dose. So obviously the inferior walls are more tricky, and Dr. Chang has written a very nice paper talking about how deep inspiratory breath hold may present a possible solution, or at least help with this feature. So I encourage everyone to take a look. With that, I just want to thank everyone for this wonderful opportunity to chat, our host and our panelists and our co-moderators, and of course my collaborators from OSU, Dr. Evan Thomas, who just joined our team, as well as our collaborators from Washington University, Phil and Cliff and Jeff, who have really kind of put forth the seminal work in this arena. So with that, I'll open up to some questions.
Thank you so much, Dr. Brownstein, for a fantastic lecture. I am sure that the discussion will be very exciting, but before we get into that, Vito, how about we briefly introduce our panelists in this session? We have a total of 5 panelists, as Vito mentioned, 2 residents and 2 radiation oncologists, 2 of which are from the Crescito Mangunkusumo Hospital, and 1 is from the Ohio State University. So Vito, would you mind introducing the first panelist?
Yeah, so the first panelist is Dr. Alex Ritter. So Dr. Alex Ritter is a radiation oncology resident from the OSUCCC. His interest is specifically in the gastrointestinal and skin cancer. Can you go on with the second one?
The second resident joining us this morning or tonight, depending on where you are, is Dr. Jayanti Bulan. She is a 3rd-year resident in radiation oncology at the Department of Radiation Oncology at the Crescito Mangunkusumo General Hospital in Jakarta, Indonesia. She graduated with her MD degree in 2016 from the Faculty of Medicine, Universitas Udayana, Bali, and started residency program in 2019. She is currently an active member of Indonesian Radiation Oncology Resident Association and actively involved in projects to improve care for patients by raising cancer awareness. And one of her interests lies in advanced radiation therapy technology.
Yep. And the next one is Dr. Andrea Arnett. Dr. Andrea Arnett is a radiation oncologist at OSUCCC. She is graduated from the University of Washington Medical School, and then completed her MD and PhD as a part of the medical scientist training program. And then she is interested in developing and promoting international efforts to improve patients' care, to patient access to care, cancer control, and survivorship support, and hopes to grow this relationship to promote meaningful and sustainable changes in international and local communities. She is a lead radiation oncologist on the Global Health Education Subcommittee, working to develop a robust university-wide global health curriculum for residents and fellows. Next one.
Our next panelist is Dr. Handoko. He is a radiation oncologist at the Department of Radiation Oncology at Dr. Sipto Mangunkusumo General Hospital in Jakarta. He graduated with his MD degree in 2013 and became a radiation oncologist in 2019, both at the Faculty of Medicine, Universitas Indonesia. His research interests lie in head and neck cancers and advanced radiation therapy technologies, and he published several pieces in recent years in the research realm, and he was a speaker or panelist at several national or international meetings recently.
Yeah, and the last one, but also our guest panelist, Dr. Ji-Hyun Chang. Dr. Ji-Hyun Chang is a radiation oncologist from South Korea, so SNU, Seoul National University College of Medicine. She has published several publications and is a principal investigator for preclinical and clinical work on cardiac ablations in South Korea. One of her ongoing trials is a clinical feasibility study of non-invasive cardiac radioablation for the treatment of ventricular tachycardia. Her specialty and interests are breast cancer, lymphoma, cardiac radioablation, and radiation-induced malignancy.
So I would like to encourage our guests to either enter their questions into the Q&A box of the chat, or if you would prefer to ask your question live, feel free to use the raise hand button. And let's get the discussion of the floor by having some of our residents on the panel ask questions. I'm sure they have many. So Dr. Ritter, do you happen to have any questions for our panelists?
Sorry, some trouble unmuting there. Yeah, thanks everyone. Thanks, Dr. Brownstein, for the presentation. I was just, one of my questions that I was curious about is, obviously as this becomes a more popular treatment method that's used, if you anticipate or have seen so far any hesitancy from patients who I think are primarily associating radiation with cancer treatment. And so as we kind of expand outside of that typical realm, if there's been any concern on behalf of patients or questions or anything from that standpoint.
So my personal experience with discussing this with patients is they're actually usually very excited. I, of course, will begin the conversation by saying, although I am a radiation oncologist, I'm not here to talk to you today regarding anything having to do with oncology. But the patients, the population that we've been treating are usually quite desperate. These are, if they have functional AICDs, are one example I presented today didn't, but a lot of them do have functional AICDs, but they'll be shopping at the store and then all of a sudden wake up on the floor with EMS all around them. And some of them have PTSD from this. They're afraid to leave their homes. They're ready to try anything. So they're very grateful that there is another opportunity to address this. So I haven't encountered that problem yet. I think perhaps if there comes a point where this is seen as an alternative to catheter ablation, that may come up. But catheter ablation is by all means the standard of care and can help a lot of these patients. So the ones that it can help are usually really eager to find something that can give them a little bit of a better quality of life.
Yeah, that's very interesting. So now we go on to the second resident on the panelist, Dr. Jayanti. Would you mind to give some comments?
Thank you for the kind introduction, Dr. Vito. Good evening, respected professor and doctor, and also good morning for college in any other parts of the world. I would like to thank Prof. Suhartati, Dr. Mayang, and also all the webinar team for inviting me as one of the panelists in this webinar. First of all, I want to say thank you to Dr. Jeremy for the interesting lecture and to share with us this new way to utilize radiotherapy for treating patients in regarding this topic, there are some questions that I would like to ask to Dr. Jeremy. My first question is, does the CRA only applies for single focal lesion? How do we treat and define the target volume for multifocal lesion arrhythmia, such as in the polymorphic VT? And then just now, you've explained about the 17 segment model recommended by the American Heart Association for the left ventricle. Is there any difference you suggest if the arrhythmogenic foci that we wanted to irradiate is located in the right ventricle? And for the last, one of the challenging issue in delivering the CRA that I can thought of is how do you ensure the given dose will hit the right target? Something that poses a challenge due to heart and also respiratory movement. Do you have any suggestion to minimize this potential geographical miss that could happen? Thank you.
So those are all excellent questions. Starting off with and I'm going to answer as a non-cardiologist. So for any cardiologist listening, if I misspeak, I do apologize. I am not a cardiologist. And I depend very heavily on my colleagues in cardiology to help make sure that we're finding the right area. And but my understanding of polymorphic ventricular tachycardia, it tends not. My understanding is that a lot of times it doesn't have to do with a culprit part of the heart, but rather a predisposition due to electrolyte abnormalities or sometimes a genetic syndrome. But it's not that there's a dysfunctional area in the heart that's causing the problem. So I don't think that we would be using this modality for that. I think the preferred treatment, for someone who has like something, when I think of polymorphic ventricular tachycardia, I think of torsade de pointe, which is this migrating ventricular tachycardia due to long prolongation of the QTC interval. And in those cases, my understanding is that the best treatment is something intravenous, like magnesium or whatever other abnormality, correcting electrolyte abnormalities or things along those lines. Now, regarding the right ventricle, this brings up a really interesting question. So speaking with my colleagues, this came up very recently with one of the cases we're working on right now. We are talking about re-entry ventricular tachycardia, but that's not most of the ventricular tachycardias that the electrophysiologists are ablating. A lot of times they'll have a focal ventricular tachycardia that's not a re-entrant loop, but and this is my non-cardiologist understanding of this, there's an area that is just kind of an area of increased automaticity. And these don't necessarily need to happen in the left ventricle, and they can happen in the outflow tracts and various parts of the heart. It seems like, at least what my group has experienced, those are they're more common, right ventricular targets and also the outflow tract targets, but they're more likely to be something that is successfully treated with catheter ablation. It's the isthmus reentry ventricular tachycardias, at least in the group that I've been working with, that are most likely to not be able to, that are be unresponsive. And the reason that the left ventricle tends to be the site that we're targeting most frequently is because it's thickest. So if you imagine that the cardiologists are using a catheter to ablate the endocardial surface, but if the isthmus is actually deeper into the myocardium, they might not be able to get their thermal energy that far deep. And my understanding is that's why we're primarily treating the left ventricle with our modality, is because those are the patients for whom the catheter ablation doesn't work, and we never see the patients when the catheter ablation does work. So I do think right now I'm working on an outflow tract patient that failed numerous ablations, and I had to kind of learn an entire different set of anatomical features for this case. I do think as this modality becomes a little bit more widespread, there may be additional indications and there may be more reason to learn more anatomy. And I know that some people are even questioning its utility with other types of arrhythmias as well, like refractory atrial fibrillation. And all of these questions are probably going to be asked in a formal trial setting in the future. So that's my understanding of why most of the patients I'm encountering are the left ventricle, and that's why we focus on the anatomy of the left ventricle at this point.
Before we continue to the another questions, I would like to deliver my honor to our President Director of Dr. Cipto Mangunkusumo Hospital here, Dr. Liz Dina, who happens to be a cardiologist consultant as well. Thank you for your support always, Dr. Liz. And also here we have a prominent cardiologist, Dr. Sunu. I would like to invite Dr. Sunu to give a comment or join the discussions, please, if you would like. Also, Dr. Liz, if you have any comments.
Good evening. Sorry, I'm Sunu. Yeah. Good evening, Prof. Tati, Dr. Liz.
Good evening.
Dr. Jeremy.
We know
Can
that you are the expert for arrhythmia. So thank you very much.
Yeah, this is interesting issue, Prof. Tati. And may I give comment to Dr. Jeremy?
Yes.
Yeah.
Please.
And the radio ablation for arrhythmia, I believe, especially used for the scar-related ventricular tachycardia. There are many other type of arrhythmia, like atrial fibrillation or idiopathic ventricular arrhythmia. But I don't think it is the proper way to use the radioablations for those fields, because there is no scar actually, like the idiopathic VT in the right ventricular outflow tract. If we identify from the MRI, almost no scar, but mostly the prolong of T1 map. Yeah. But for scar VT, especially for VT due to the ischemic heart disease, yeah, it is related to the presence of scar in the left ventricle, mostly in the left ventricle. And as Dr. Jeremy mentioned beautifully in the presentation, actually in this method of radio ablation, similar with the homogenization of the scar. Previously, when we do the ablation of VT, of ventricular arrhythmia, scar VT, due to the ischemic heart disease or due to the heart failure or cardiomyopathy, we homogenize those scar to eliminate all the area of the circuit of reentry, the entrance, the isthmus, and also the exit. But currently, actually, Dr. Jeremy, I don't know if you are aware or not with Dr. Roderick Tang from Chicago University.
I certainly heard the name, yes.
Yeah, he's very famous on the VT ablation, and I follow actually his method to map and ablate the VT using the ILAM, so-called the late action mapping. And if we do only based on the ECG, this will represent the exit side of the circuit. Yeah, it is not the isthmus actually.
Yes.
So the isthmus will go to the exit, and the exit can go to the mid or to the apex of the ventricle, depend on the area that this conduction can go. So if we only based on the mapping based on the ECG, I'm afraid that actually we will mostly eliminate the exit site. Therefore, maybe my understanding here, Dr. Jeremy, we should combine this between this radio ablation with the 3D mapping so that we could get better results for the patients. Thank you, Dr. Thank you, Dr. Jeremy.
I couldn't agree more with what you had to say. And I will firstly say that we are, every case up until this last case has been a scar-based re-entry VT. And the only time I've encountered this outflow track issue was in this most recent patient. And it was just, the issue is that this patient has undergone a number of catheter ablations, and it doesn't seem to be taking, but they're able to induce the VT very specific from a very specific location. So I will say my limited understanding of cardiology, and I appreciate you filling in some gaps. My limited understanding has been that we aren't really targeting the exit site per se, but we are assuming, and this may not always be the case, we are assuming the exit site is located at some proximal location to, or some location close to the isthmus. So we are almost always using our electroanatomical maps that our cardiologists are producing. And that's one of the things. There's only been 1 or 2 patients we couldn't, and that was merely because of an access issue in terms of mechanical valves. But for the most part, that is a staple modality that our cardiologists, I am not selecting the target. I am having just a conversation with our electrophysiology team, and they are doing the selection. But that's a study that's usually taken place, and they're usually acquiring that study while they're potentially trying to do the ablation as well. That had been unsuccessful. And then in addition to that electrical anatomical map, which unfortunately, as of now, we can't pull into our treatment planning system directly, but we're working on that to see if we can actually just fuse that in, because that's a super helpful. It tells you information about both the scar and also areas where pace mapping is successful and things like that. We are also, in addition to that, frequently getting a PET scan, a cardiac PET, and we're using that to visualize the scar, knowing that the isthmus is likely to be either within scar or on the boundary of scar, and on the intermediate conduction zones on the electrical anatomical map. So the exit site that we're finding from the EKG, we're using that to kind of think of the area that is likely going to be adjacent to our target.
Yeah. Do you use also MRI to identify the scar prior to the ablation?
We try. We have tried on 1 or 2 patients. We're going to try to do this more in the future. The issue is that the patient has to have a newer model. A lot of them are going to be having AICDs or pacemakers or both, and they have to have a newer model that's MRI compatible. And we also have to use a low Tesla MRI. So the stars haven't aligned, and also unfortunately we have a little bit of a backlog with some of our MRI or some of our MRIs. We're going to be getting a new one in one of our research facilities that'll be available. I'd like to use it more. I understand the late gadolinium enhancement is supposed to be an excellent surrogate for scar, and I think that'll be very helpful. But for right now, the easiest study for us to acquire in a short period of time is the PET, and that's what we've kind of been using as a way to know, to further quantify scar beyond the electroanatomical mapping.
Okay, thank you, Dr. Jeremy. Thank you, moderator.
Thank you, Dr. Suno. And Dr. Liz, do you have any comments to add on? Can we like?
No, it was very interesting, and I really enjoyed the discussion. So for me, it's no comment anymore. Thank you.
Thank you very much. Thank you very much, Dr. Liz. And then can we continue to? Yep, Nico, please.
Thank you so much for your input. It was a very interesting conversation to have a listen to, definitely very insightful. And I had a question for Dr. Chang. To my limited understanding, patients who receive heart transplants are often prone to arrhythmias. At the same time, my understanding is that the anatomy is often altered. Would you consider this approach appropriate for transplant patients at all?
You mean the patient who had transplant already?
Mm-hmm. Should they develop arrhythmia that would be not amenable to ablation, would you perhaps consider offering this at all?
We haven't the case yet, but I think it would be a little bit difficult to apply radioablation to them because they all also received surgery once, and the vessels would be very vulnerable to stenosis or other things. So I think it would be a little bit more difficult to apply radioablation to them. But I don't have any experiences for the patients who had transplants already. So is that you wanted, Dr.?
Yeah, that was my question. Yeah,
Yes.
absolutely. Thank you so much for your input. And we have some very interesting questions in the chat. I will start with a question posed by Teuku Muhammad Khalid, who is a radiation oncology resident at the University of Indonesia. And his question was, in your experience, in case to prevent evolving malignant arrhythmia caused by MCI, what is faster, the preparation to do primary catheteric cardiac intervention compared to radioablation? And is there any place to do cardiac radioablation post-thrombotic radiotherapy? Whoever wants to grab that question.
So I will say that the first choice, at least in our institution, is usually the invasive cardiology procedures. If the patient is unstable or has the potential to be very unstable, the electrophysiologists have at their disposal a lot of tools that can rapidly arrest a dangerous arrhythmia. We are not cardiologists, and we do not, if the patient is having trouble on our table, all we can do is call the code team, whereas the electrophysiologists are able to actually help. And I'd say, again, the catheter-based solutions are always going to be the first choice, and they are the standard of care. And the last point I'd make is that the radiation planning process at our institution, especially if we're dealing with a sensitive area like the heart, is going to be taking usually more than 2 weeks. On these cases, from the time the patient is simulated until the time they're treated can be more than 2 weeks, because there has to be a conversation with the cardiologists before I even submit my volumes to have our physicists plan them. And if there's a difficult or atypical situation, we are frequently discussing this with our colleagues at Washington University, who have more experience than we do. So we are not treating patients emergently, and we're not trying to rush and do it quickly. And I think electrophysiologists can treat patients emergently and rush and do things quickly. So I would say the role for us is, if their methods are not working, then we consider our method as a fallback.
Yeah, thank you.
That makes complete sense.
Yeah. Can we continue to the next question?
The next question is by Dr. Randa Prasad Roy.
Yeah. No,
his question
I think there's another question from the chat box. Can we go to the chat box first? Here there's a Prof. Imjai from Thailand, and also this is in conjunction with the questions from Dr. Eko Kuncoro from Indonesia. Is there any myocardium volume limitations in this novelty treatment? And in long term, with relatively high single radiation dose and large PTV, are there any risk of myocardial perforation? Please, Dr. Brown, or any other panelists can give any comments?
So this is a very nascent field at this point. So it's important to know that we don't know at what size of a target we're going to run into trouble. And we don't know long-term complications with a large number of people, because this hasn't been done for very long. I don't think so. The biggest issues that in speaking with Phil and Cliff, that are encountered have to do one of the major problems is damage or fistulization with GI organs, with the esophagus or the stomach. And that is one of the biggest risks given the location, especially for those inferior wall areas. Another concern is in someone with very poor very significant heart failure, making that heart failure worse by killing viable myocardium. So that is my limit of 150 cc's is arbitrary and is based on the fact that most of the patients treated at Washington University had targets smaller than that. But the rupture is not as much of a concern as the damage to functional myocardium, and certainly not as much of a concern as damage to the GI organs, at least in my limited experience. I don't know if Dr. Chang has encountered anything else besides those problems.
As Dr. Brownstein said, the GI problem would be the most dreadful toxicity because according to the Ostrava group, they reported esophageal fistula, which resulted into death. And also the WashU group has had one grade 4 gastropericardial fistula, but the patient survived. So we reported a case report that the patient was very close to, the scar was very close to the stomach, and we applied DIBH, deep inspirational breath hold, and we could successfully depart the stomach from the target, so we could make the dose under the critical dose. So we very encouraged the radiation oncologists to apply those techniques for to avoid the GI toxicity. And I could see one additional question who asked about myocardial perforation. And we underwent animal study, which we radiate the rats up to 50 degrees, but we did not experience any perforations, but we had fibrosis.
Dr. Annette, do you have any add-on?
Yeah, I just wanted to follow up kind of a question or just a topic of consideration for in relation to the GI toxicity. I can see how it would be quite a concern for these patients. However, of course, you're going to have to be balancing the risk of GI toxicity with the risk of lowering the dose to the point that you may not be effective in your radioablation. So it's a precarious balance there, especially when it's right up against the diaphragm or against the esophagus. One thing I was considering though is that a lot of GI complications, since I more commonly treat more GI disorders, a lot of GI issues can be surgically managed either endoscopically or with larger surgeries. And so if you're really balancing, I'm wondering how much that comes into play and how successful we can be at still being aggressive with the heart with treatment of the electrophysiologic abnormalities, knowing that we could potentially, if we monitor those patients closely, manage any GI complications that come up down the road, either through resection, endoscopic repair, or just with more frequent monitoring of these patients.
To my knowledge, the patients with those arrhythmias have very limited heart ejection fraction, so they are very they have risk for the sedation. So we wanted to perform EGD routinely, but it could be very careful for them.
Yes, that makes sense.
And one thing, in kind of anecdotally speaking with my colleagues at Washington University, there may be some preclinical evidence that 25 gray is kind of an arbitrary kind of dose, and there's nothing to suggest that that's the bare minimum that you need. So there's some preclinical data to show doses as low as 15 gray times 1 can kind of induce the formation of scar, which is the goal. So I think one of the important early questions after this is established as a in America, an FDA approved technique is going to be a dose de-escalation study to see if lower doses are as effective. And then if they are, we can remove the threat or lessen the threat of GI toxicity by giving less radiation.
Mm-hmm. I'm very interested in seeing how the long-term data on long-term toxicity and outcomes data in terms of efficacy come together for these population of patients, because this is such a new field that it's going to be exciting to get that information.
Absolutely, Dr. Arnett. An interesting kind of technical question from Salih Havari is, if we only have access to EKG and CT simulation, and that's all we have, would you recommend we consider this technique for a patient who has no other options? And how accurate do you think the scar location or the target location can be with only EKG and CT simulation and no MRI, no PET scan, nothing else? Dr. Brasi, you're muted, I think.
In oncology, we're often kind of faced with many times when we have very limited information trying to prescribe treatments. I would say that that would make me pretty nervous at this point. If there were a patient in those circumstances and there weren't other studies available because they weren't necessarily available at the institution, I would endeavor to try to have the patient seen at an institution that can give you some additional information, because this is there are likely patients who have been retreated with this technique, but from my perspective, I think of this as most likely a one-shot technique, and I wouldn't want to miss the target because of limited information, and then kind of ruin the chance of targeting the appropriate area at a later time. So I would be nervous about doing that. I also, it's a new field, and because we are just now developing this possibility of using this technique, and we don't know its limits, and we're still convincing colleagues that this is an appropriate thing to consider for some patients, I think it's wise to try to make sure that we're being as careful as possible and as thorough as possible in terms of getting the right target and having experts from electrophysiology on board who are confident in a target location and making sure they have all the studies that they would need.
Thank you.
Dr. Chang, how do you feel about that question?
Oh, Dr. Chang, please.
Well, I always discuss with my colleagues. So if my colleague cardiologist is confident with it, I will try. I was always nervous treating the patient first, but at first time we should be cautious and try to communicate with cardiologists, and we should rely on them. we cannot judge with if we could treat the patient or not in the first time if we have very limited data. Can I ask a question?
Of course.
I think the 17 segment concept would be very important for communication with cardiologists. But the thing is, it could be very labor intensive. So my first question is that how much time do you spend to delineate the 17 segments? And the second one is there an effort to automate the process?
So those are excellent questions. I don't necessarily delineate, or I don't at all delineate the 17 segments on every patient. Typically, the cardiologists that I work with have they are describing to me the location of the target in terms of some of the segments. And I do as much of the segmentation as is necessary to find those segments. So like, you know, I'll rotate the heart into the appropriate views. And let's say we're targeting an apical segment, segment 14, the septal apical segment. I'll measure the long axis and divide it into thirds, and then look at just the apical third, and then I will delineate the 90-degree arc that is kind of taken up by the septal wall. So in that case, I'm not even going anywhere near the base. So I don't do the whole thing on every case. I had created the atlas so that there was, if you can find the segment that's relevant to your case on the atlas, but that's certainly I probably wouldn't get much sleep if I did that on all of my patients. As to the second question, the answer is yes. There are groups that are looking at auto segmentation and also interpreting how the information can be synthesized into how you can synthesize a segment target based upon the electrical information. So there's certainly a lot of work in those arenas, and I think there may come a day in the near future where we are not necessarily choosing the initial target, but rather confirming the predicted target. But I think understanding the anatomy is going to still be extremely important because we're going to be signing these prescriptions. So we want to make sure, even if there's a great computer program, that we're all in agreement that we're targeting the right place and that we understand how to find those places.
Yep. Can we jump to the more basic questions? This is from Dr. Tomoaki Tamaki from Japan. What is the reasoning for the prescribed dose, cell kill, functional modification of the cell, or functional annihilations of the cell? Is the target nucleus or DNA or other cellular apparatus? Any comments on this?
So I admit I don't have an extremely deep understanding of the cellular effects, but my understanding is that the goal is to achieve what cardiologists are trying to achieve as well, which is homogenization of the scar. And the issue that we're addressing is an area of conductivity in the isthmus, and especially the critical site. And I would encourage any cardiology colleagues who are on the call to chime in and correct me or add to what I'm saying. So we're targeting that area with the goal of making it non-permeable to electricity at all, so that there's no slowed conduction, so that the electrical connections between the cells do not foster any connection, so that there's no slowed conduction, there's no conduction. So it's essentially turning into fibrotic scar. So that's my understanding. And then with regard to dose, we don't, I know that there are preclinical data to support the 25 gray times 1, but we don't know if that is the minimum dose that will achieve our goals. And that's going to be an important question. And preclinical data may or may not answer this question, as well as human data, because obviously mouse hearts are different than people hearts. So I think once this technique is established with regulatory agencies as an acceptable treatment, it'll be great to ask the question of dose de-escalation and seeing if less dose can achieve the same results.
Wonderful, thank you for answering that question. Another very practical question from Putra Antara. Do you have a maximal tolerable heart rate for performing the radiation ablation?
So it's important to note that these patients are usually not in ventricular tachycardia when I'm treating them. And that may be something that I should have specified. So these patients are, when they are in ventricular tachycardia, most of the time they're unstable and they're not coming to our department. And it's also important to know that the treatment, give or take, takes about 6 weeks to take full effect. So the response of the radiation, the fibrosis and scarring is not immediate. So I personally am not, especially in these cases where we're trying to be very precise in the treatment time, it could be a little bit longer because it's such a high dose. I am not comfortable having a patient who is remotely unstable undergo this treatment and asking them to be perfectly still and sometimes putting abdominal compression on. Those are not things that I would do when someone who, you know, if their heart rate is around 100 and they're in a sinus tachycardia, that's just fine. But otherwise, I'm not very excited about the prospect of treating someone who's remotely unstable.
Okay, wonderful. So we continue to the next questions from Chiang Mai, Thailand. Should we treat the patients in free breathing or breath hold condition? And what is the suitable device for motion management? Do we need to use tracking or CBCT is enough? And this question is also correlate to the next questions from Korea as well. Dr. Gyu Sang-yo from Samsung Medical Center. The case shown in the presentation seems to use the simulation CT gated with cardiac cycle, doesn't it? Do you use also the beam delivery with gating according to the cardiac cycle? Because the heartbeat continue, the location of the target always change due to the heartbeat as well as patient's breathing. Do you think the 5 mm of the ITT margins will be sufficient? I think cardiac gating RT is not technically difficult. Thank you. Anyone?
Well, I will say these are all excellent questions, and I'll give my input, and then I'll defer to Dr. Cheng as well, who you know has published on this topic. So at our institution, we've done both free breathing and breath hold. Well, I wouldn't say breath hold. We've done free breathing and free breathing gating, and we are considering breath hold as well. But the question of how to incorporate motion management. So we are typically getting a 4D simulation scan that is gated to the respiratory cycle and not the cardiac cycle. So the cardiac EKG gated CAT scan that we sometimes will be using will be done gated to the cardiac cycle, but that is not our simulation scan. So our simulation scan is to the respiratory cycle. And what we have done is we will look as the heart, you can see some degree of heart movement, not consistent and not necessarily reliable on our CAT scan on the 4D component of it. And you can get a sense for how much a wall is moving in certain directions, you know, from the point of when it's in diastole and kind of furthest filled to the point when it's contracting. You can sometimes get a good sense of that. A lot of times the wall that we're treating is a little bit hypokinetic because there's scar there, not always, but that will be incorporated into the ITV, and then so will the respiratory motion will be incorporated into the ITV. And what I was mentioning that Cliff and Phil use a lot, and what I will fall back on is if you find the wall or even a portion of the wall that you can identify on the scans, and you try to figure out the maximum excursion going through all the different cycles of your 4D gated respiratory scan, and you make a ITV margin that expands to that maximum excursion in all of those directions. That's kind of a fairly inclusive way to try to make sure you're including the appropriate area in the target. And then we, beyond that, are doing a 5 millimeter PTV expansion. And so we're generally doing free breathing with abdominal compression. We are considering starting breath hold. In terms of our physicists want to make sure that we have a reproducible way to make sure, especially with these cases, that our breath hold understanding is accurate, and we may be acquiring a system that'll help us with that. But we're using free breathing for the most part, and when we're delivering the treatment, we're using VMAT arcs, and we'll sometimes obtain 2 or 3 interim. If we're doing 2 or 3 arcs, we'll obtain a cone beam at the beginning of treatment, but also after each arc to realign to the heart to make sure we're being as accurate as possible.
Thank you so much for the answer. In the interest of time, I will interpret question by Julius Entario. Are you worried at the same time, and as you mentioned, you extend the ITV to the walls, about causing fibrosis in the healthy myocardium, perhaps as a long-term side effect and weakening the heart? And what kind of studies should we carry out in order to learn more about the safety and efficacy of this approach?
These are excellent questions. These are all the questions that I find myself asking myself. There is always concern about causing, especially in people with tenuous heart function, that we're going to make matters worse. We try to really, so the PET scan for me is a helpful tool that I fuse in to our planning scans, and I'm trying really to avoid healthy myocardium. Sometimes our expansions will bring us into healthy myocardium, and that's difficult, but I will try my best to avoid having that be in the target. And I also use that 150 cc upper target size to try to limit the amount of heart I'm exposing to this high dose of radiation. In terms of before and after studies, one of the things that we are looking at doing, first of all, these patients are getting frequent echoes, and those are, of course, are helpful. But we have a collaboration with a research institute at OSU that does a lot of radiology. And we're going to be trying to get before and after PET scans on our patients to try and understand how the size and uptake in the scar and the adjacent areas is changing at different time points before and after treatment. And we can kind of get a sense for which isodose line of radiation seems to be affecting healthy myocardium in terms of making it less viable.
Excellent, thank you so much. And you talked about the 25 gray in 1 as the dose. For centers that just don't have robust movement management system, what is the minimum dose they could consider, if there is a minimum dose?
I don't know that we know the answer to that yet. And I would say that the challenge here is that we can't really, so if we know that a lower dose is effective, then that's great. But I don't think things like fractionating are necessarily, I don't know if that's where the question was going, but things along those lines may not be as helpful because our target is normal tissue and causing actual normal tissue toxicity on purpose. inducing fibrosis. So I don't know, there may be, but I don't know that there's going to be any leverage to fractionation. And I am hopeful in the future we discover that a lower dose is effective, but we don't know that yet. And I would also say that this is a time, I think, when the motion management, it's very important to have motion management when doing this. And if there's down the road a framework that uses more sparse motion management technology that seems to be successful and is identified to be safe, I think that that's a reasonable approach under those conditions. But right now, I think, given how little we know, we would want to be using robust motion management and also using the dose that we know to be effective, with the exception of maybe underdosing areas near GI organs and things like that.
That makes total sense.
all.
And Dr. Cheng and Dr. Brownstein, if someone has a pacemaker or AICD, what is the constraint you use for those, if you use one?
So there's in this case, there's I believe it's AAPM has some guidance on the pacemaker, what's considered a low risk, a medium risk, and a high risk. If the pacemaker can be moved away from the target safely, if the patient can undergo that procedure, we might do that. But in terms of low, intermediate, and high risk, and this is just off the top of my head, I could be wrong. I think low risk is less than 2 gray, intermediate risk is 2 to 5 gray, and then high risk is above 5 gray. And if it is high risk or intermediate risk, I think the solution is to either replace it or diligently interrogate it. And another technique or consideration that's important from a radiation oncology perspective is if you keep your beam energy below 10 MV, you're below the point where you can start getting neutron production, and neutrons are what are most damaging to electronics. So having like 6 MV beam near a pacemaker, I think, is another way to maintain safety. But I think, whereas damaging GI organs may be a bridge too far, damaging a pacemaker, I think, is of a lesser concern. If this is the only treatment they have available, pacemakers can be replaced a lot of times.
Actually, the pacemaker machine itself is very far from the heart, and we can concern about the lead, but lead is also almost within the target, and we did not experience any problems after that. And the machine itself is very far, so we see that the dose is very low in the device, so we don't care about it.
That's been my experience as well. It hasn't really come up as much as it has in lung cases that I'm treating, because it's usually far above the level of the heart. The one time something along these lines came up was when we were considering an LVAD patient, where the actual motor itself was in the apex, and that's where our target was. We didn't end up treating that patient. There were too many. I think the patient actually wasn't ultimately didn't pursue treatment, and there were a lot of variables. But pacemaker dose hasn't been a problem for us yet with these cardiac treatments. I encounter it more commonly with SBRT for lung cancer.
But the lead itself can be problematic, so our cardiologist check it after the radioablation, check the stability of it. And one more thing about the dose, our team has performed several in vivo experiments, and we found that the early change could be different from late changes, which is fibrosis. And we think we have a hypothesis that the early changes came from the inflammation. Inflammation makes the antiarrhythmic effects, which is different from later fibrotic effects. So it is a hypothesis now, but we are trying to figure out about that, because fibrosis comes very later than we expect, but we see the patients get resolved before than we expected.
Thank you. Now, Dr. Handoko, do you have any comments on anything in this session?
Yeah, thank you, Vito. So thanks, Dr. Jeremy. I guess I have a lot of questions, but I will limit it to a few because of time zone. And one basic question is, you explain about the isthmus. So there's entrance zone, isthmus, and then an exit. It's like a tunnel. And you mentioned that our main target is the exit zone and the scar tissue around it. I'm wondering why you don't target the entrance zone. And then the second question is, as the normal myocardial muscles can be affected by high radiation dose, how is your clinical experience? Any risk of further deterioration of the heart failure in the patients that you have treated? And then one more question, radiation oncology specific question. How do you assess the dose fall off? So, for example, in lung SBRT, we use R15. Do you use something like that to assess how good it is your low dose region? Maybe I limit it to that questions. Thank you.
So those are all excellent questions. Our first question is an important point because I don't want to give the wrong impression. The entrance to the isthmus, otherwise known as the critical zone, and again, I encourage my cardiology colleagues on this call to correct me if I'm wrong. We're mostly targeting the critical zone and the isthmus, and the exit site is not necessarily the target. It's just that the exit site is easiest to observe. So when we're looking at the EKG, we're seeing the vector of the outer loop that's originating at the exit site. So that is the part of the isthmus, or one, when we're looking at the EKG, that is most observable. And what we're really trying to target is the isthmus and the critical zone, the entrance area of the isthmus. That's the major target. It's just harder to know exactly where that is with the data. So that's why the exit site is likely to be near or touching the target, but the target itself is going to be adjacent, and the target ideally includes the critical zone. So that was the first question. Remind me the second question again. I apologize.
Okay. So the second question is, there's a risk of irradiating normal myocardium, so the risk of heart failure.
So we haven't observed this fortunately that much. There may be one patient we have whose heart function may have worsened, but it's unclear it has anything to do with the treatment we're investigating, but it wasn't a significant worsening. That's not to say this is completely safe in terms of adjacent heart. And I think the key is to minimize healthy myocardium in the target itself, and to try to make sure that the targets aren't unduly large. Some people are talking about whether or not we can target 2 foci or 2 isthmuses in one treatment. I personally have not gone down that road yet. I like to keep it with as small of a target as possible, because I share that concern that you don't want to make someone who's just compensating with their heart failure go into decompensated heart failure. And in terms of the third question, With the radiation dose fall off, we tend to use the similar parameters that we will use for long SBRT. I mean, our target is not terribly dissimilar from what you would imagine an SBRT target is. So we try to have our conformality indices be as low as possible. And I'm trying to remember the specific values. I think we try to keep it below 2. That may be wrong, that's just off the top of my head, but we're essentially trying to get as conformal of a treatment, and we'll be using VMAT with multiple arcs to try to accomplish that.
Thank you so much, Dr. Brownstein. This was a fantastic session, and I most sincerely thank all our panelists for this. I have personally learned a tremendous amount, and I hope that so have our guests. Dr. Arnett, would you be perhaps prepared to give a few brief closing remarks, perhaps in the context of these 2 sessions that we've now had?
Yes, thank you very much again, everybody, for coming together and attending across huge time zone differences. And it's just amazing to see so many different countries coming together to learn and to do it in such a friendly and supportive manner where there's a genuine interest in learning from each other. I think this is a wonderful resource here, and I appreciate everyone's efforts. We're hoping to continue the webinar series and other topics that are of interest. So again, thank you for everybody for participating and putting a tremendous amount of work into this. I also, speaking specifically to our topic today, I think it's great that we've had so many questions about motion management, imaging, and discussion about how this technique could be applied in different settings with different complexity of data acquisition, imaging, and motion management, because I think ultimately each of us has different setups and different access to different resources. So the more that we can see this applied across different modalities and with the idea to reduce the complexity to a level that's safe for the patient, but is still attainable by many different institutions, would be the best for our patients. Obviously, this is new, it's a new technique. Everything is just in its nascent time, but ultimately it'd be great to make sure that this is as accessible as possible, because it's a great option for patient treatment. So thank you.
Thank you, Dr. Arnett. And Prof. Suhartati, would you mind to give any closing remarks? Prof. Suhartati, you haven't unmuted yourself.
Yeah, thank you very much. So finally, we are at the end of the time. Yes, this was very interesting topic that opened new horizon in the field of using radiation in non-malignant condition. Hope that this information will increase our knowledge, and thanks a lot to our friends from Ohio State University under the coordination of Professor Andrea, and also Dr. Jeremy, Nicole, Alex, and Dr. G, Dr. Chang from Korea. And also thank you to our team, Dr. Mayang, Vito, Gea, and Handoko, and also to our two cardiologists, the expert cardiologist expert in arrhythmia, Dr. Sunu, and also Dr. Liz. It's already left because he has another appointment. And thanks to all attendants. Very important is all the attendance. We have still 233 attendants right now at the end of the time. And the last but not least is thank you to our IRORA, Indonesian Radiation Oncology Residents Association, as well as also the residents from the Ohio State University to run this webinar very well. So thank you very much. All the best for all of you. Stay safe and healthy, and see you in the next collaboration webinar between Ohio State University and the IROS. Thank you very much.
Thank you, Professor Suhartati. Now, before we close the sessions, I would like to invite all the panelists and also the speakers. Professor Suhartati, everyone, please kindly open your camera so we can take a group pictures. The committee, please kindly assist us.
Prof. Kasi, please open your video.
Prof. Kazi, would you mind to open your video as well?
Okay, I will take picture. Please hold your position for 3 seconds. 3, 2, 1. Okay, I will take picture one more time. 3, 2, 1. Okay, for the last time. 3, 2, 1, smile. Okay, thank you, Prof. and doctors.
Okay, I think that's the end of our sessions. We would like to officially close these sessions. Thank you everyone for your participations and look forward for our next webinar, which will be announced soon. Stay tuned. Good morning, good evening, everyone.
Thank you.
Bye.
Thank you, everybody.